Welcome to the Explainer. If you've cracked open the urology chapter recently, you know it is incredibly dense. It's like a giant puzzle. But today, we're going to cut right through all that noise. We are distilling this entire chapter down to exactly what you need to know. We'll pull out the high-yield pathophysiology, the absolute must-know nursing interventions, and those critical safety alerts that are going to make you a fantastic nurse and a totally confident test taker.
Here's our game plan for today. We'll hit 5 key areas: infections and inflammations, obstructions like renal calculi, acute and chronic kidney failure, dialysis and nursing care, and finally, we'll wrap up with the top 10 NCLEX takeaways.
All right, let's jump right into Section 1, Infections and Inflammations.
When you're teaching patients about uncomplicated cystitis, that really uncomfortable bladder inflammation, usually caused by bacteria, you want to focus on actionable prevention. You're going to teach your female patients to always wipe from front to back to avoid dragging bowel bacteria up to the urethra. Instruct them to void before and after intercourse to flush the area out. You'll also want to encourage a really high fluid intake, at least 30 milliliters per kilogram of body weight every single day. Oh, and tell them to skip the bubble baths and vaginal deodorant sprays. Those are just notorious for causing irritation.
Now this next one is an absolute classic board question. Phenazopyridine, which you'll often see as pyridium, is a fantastic medication. It relieves that awful burning sensation when they pee. But, and this is a huge but, you absolutely must warn your patients that it turns their urine bright orange red. Seriously, if you skip this patient teaching, they're going to panic, thinking they're bleeding internally, not to mention their clothes might get permanently stained. It's a really simple teaching point, but it's absolutely vital.
Moving right along, let's talk about what happens when the plumbing gets blocked in Section 2, obstructions, specifically renal calculi.
When a patient has a stubborn kidney stone, one of the most common medical interventions is ESWL, or extracorporeal shockwave lithotripsy. It's a non-invasive procedure that basically uses targeted sound or laser wave energy from outside the body to shatter stones right inside the ureter. It breaks that massive, unpassable stone into tiny little fragments so the patient can actually pass them naturally in their urine over the next few weeks.
So, what are your nursing priorities when a patient is passing these fragments, either naturally or after getting ESWL? Well, you have to be highly active. You must strain all of their urine through a filter to catch the stones for lab analysis. We have to know exactly what that stone is made of to prevent future ones, right? You also need to aggressively push fluids, ideally to a minimum of 2 liters a day unless it's contraindicated, to keep the urine dilute. And remember, renal colic causes excruciating pain. Administering those ordered analgesics promptly and getting them up and ambulating to help the stone move are top priorities.
Things escalate significantly here in Section 3 as we transition into acute and chronic kidney failure.
Before we dive deeper, we've got to lock in some vocabulary so you don't get tripped up on exam day. Azotemia is the chemical buildup in the blood. It's what you see on a lab panel, specifically those increased nitrogenous waste products like BUN and creatinine. Uremia, on the flip side, is the actual physical presentation of that toxicity in your patient when their kidneys can't maintain fluid and electrolyte balance anymore. Uremia is what gives you symptoms like nausea, vomiting, confusion, and peripheral neuropathy.
So you really need to understand the difference between the two main types of failure. Acute kidney injury, or AKI, hits fast, usually within 1 to 7 days. And the golden rule here is that it is potentially reversible if we catch the underlying cause quickly. Chronic kidney disease, or CKD, is totally different. It's a slow, one-way street of progressive, irreversible nephron destruction over months or even years, ultimately leading to end-stage renal disease.
I love breaking down the 4 phases of AKI because it makes the progression so clear. You start with the onset phase, which is pretty short. Then you hit the oliguric phase. This is where urine output just plummets to less than 400 milliliters a day, and you see BUN and creatinine sharply rising. Then, as the kidneys finally start to heal, the patient enters the diuretic phase. Here, urine output spikes dramatically, sometimes over 4 liters a day. And finally, you have the recovery phase, which can actually take up to a year for kidney function to slowly normalize.
Okay, let's test your clinical judgment for a second. Based on what happens when urine output drops below 400 milliliters a day during that oliguric phase, why must we immediately hook this patient up to a cardiac monitor and watch their EKG like a hawk? Think about what the kidneys normally excrete.
If you're thinking potassium, you hit the nail on the head. During oliguria, the kidneys simply cannot excrete potassium. The resulting hyperkalemia is a life-threatening trigger for severe, lethal cardiac dysrhythmias.
If you see a patient in AKI whose urine output is dropping, your brain should immediately flash a massive warning sign about their potassium levels and their heart rhythm.
For patients whose kidneys can no longer manage this balance, we enter Section 4, Dialysis and Nursing Care.
Let's talk about gaining vascular access for hemodialysis, specifically the AV fistula. This is a surgical connection of an artery directly to a vein in the arm. Doing this creates a high-pressure, incredibly durable vessel that can actually withstand the heavy, rapid blood flow required by the hemodialysis machine.
Protecting that fistula is quite literally one of your primary jobs as a nurse. You must assess it regularly. You palpate, or feel, the venous side for a thrill. It's this vibrating, rippling sensation of blood moving. Then, you use your stethoscope to auscultate, or listen, for a bruit, which is a distinct swooshing sound. If you don't feel the thrill or hear the bruit, the vessel might be occluded. And here is a massive safety alert. Absolutely never, ever take a blood pressure, start an IV, or draw blood from the arm with the fistula. No exceptions.
On the flip side, we have peritoneal dialysis. Instead of filtering the blood outside the body, this method uses the patient's own abdominal lining, the peritoneum, as a semi-permeable filter. Dialysate fluid is instilled right into the abdomen, left to dwell so waste can cross the membrane, and then drained out. It gives patients way more freedom at home, but it introduces entirely different risks.
Now, what is the absolute biggest red flag you need to watch for here? It's cloudy effluent. When that fluid drains out of the abdomen, it should be clear. If it's cloudy or if it has little particles in it, that is the hallmark, telltale sign of peritonitis. That's a massive, extremely dangerous infection of the peritoneal cavity, and you need to report it to the healthcare provider immediately.
We've covered a ton of ground today. Let's bring it all together and build your confidence with Section 5, our top 10 NCLEX takeaways.
You'll definitely want to screenshot these 10 absolute highest yield points. You are almost guaranteed to see these on your upcoming ATI and NCLEX assessments. Number 1, peridium turns urine orange. Warn your patients. 2, basic hygiene. Always wipe front to back to prevent UTIs. 3, strain all urine for patients with renal calculi to catch those fragments. 4, protect that AV fistula. You must feel the thrill and hear the bruit. 5, cloudy peritoneal dialysis effluent equals peritonitis. 6, remember the timeline. AKI is rapid and potentially reversible. CKD is slow and irreversible. 7, hyperkalemia is the silent, lethal killer in oliguric renal failure. Watch that EKG. 8, daily weights are the absolute best, most reliable indicator of fluid status. Same time, same scale, same clothes. 9, monitor fistula patients' Restiel syndrome, where too much blood gets diverted from the extremity. And number 10, always question and avoid nephrotoxic medications for patients with compromised kidneys.
As you head into your exams and out onto the clinical floor, I want you to remember just how interconnected the urologic system is. It's not just about urine. It's about regulating blood pressure, maintaining perfect electrolyte balance, and clearing out dangerous toxins. Look at the whole clinical picture. Ask yourself, will you be the nurse who catches the subtle shift from a minor localized issue to a full-blown systemic crisis? I know for sure you will be. Keep studying, trust your knowledge, and I'll catch you in the next explainer.